Hello, I'm Dr. Sukile, and today I'm going to speak to you about the approach to neurological disease. This is a brief outline of my talk. So I want to just start by talking about a case. So this is a 69-year-old woman with a past medical history of hypertension, diabetes, pulmonary TB, and gastric ulcers who presents with chest pain. So what do we usually want to know? So we usually want to think about a differential diagnosis. We want to think, is this something cardiac? Is it pulmonary? Or is it gastrointestinal? And this is the hallmark of neurology. We always want to think about the localization. Where is the problem coming from? Is it from the cerebral hemispheres, from the brainstem, the spinal cord, nerve roots, nerves, neuromuscular junction, or the muscle? So we essentially start from the top and go down all the way through the neural axis. There are essential elements of history that we need to think about in neurological disorders. And the first is you want to think about the onset and how that onset occurred. So was it hyperacute? Was it acute, subacute, or chronic? And then you want to think about the progression of symptoms. So you know how something started, but what has happened since then? How has the symptoms progressed? And if they are episodic, we would like a detailed description of each entire episode. You want to think about aggravating and relieving factors, and you also want to think about how severe the episode was or how severe the symptoms are. Further on, you want to think about the past medical history. Is there any past similar presentation? Are there any systemic disorders that may be related to this neurological presentation? Is the patient on any medications, and may these medications have neurologic side effects, or may they be compounding or confounding the symptoms that you've seen? Is there a family history of similar symptoms? And then you want to think about their social history. May there be any exposures that are related to the presentation? And this could be contacts with someone else who is ill, contacts with pets and animals, or a travel history, and so on. After you've got your detailed history and after you've started thinking about which systems might be involved in your history, you then go into the neurological exam. So the neurological examination is also done very systematically. And the way I'll outline it here is how we expect you to always do a neurological exam. And that's also how you should present when you present a patient with the neurological symptoms. So the first thing that we always do is the mental status and the higher functions. So you want to look at the level of alertness. You want to look at the orientation. Is your patient oriented to time, place, and person? Are they attentive? And how is their memory? And when we test memory, we talk about immediate recall. So something that they can recall within 5 minutes, and that's usually maybe where you give them 3 words, then you ask them to repeat those words back to you, or you show them 3 objects and ask them immediately where those objects are hidden, for example. And then a delayed recall is something that will happen a bit longer later. So maybe 10 minutes later, you try and ask them, what were those words I gave you in the beginning? Or if you hid 3 objects around the room, you say, where did I hide those objects? Further on in your higher function, you want to look at the language. And with language, we comment on fluency, which is something you can actually assess as you speak in conversation with the patient, though you could also ask them, for example, to spontaneously say a sentence or ask them to name, say, a group of things like name animals or name words beginning with the letter F, for example. You look at naming. Are they able to name objects around them? So you can look at simple common objects and again, more uncommon objects. So for example, a simple object would be asking them to name a phone or a watch or a pen, and then more complex objects like asking them to name a stethoscope, for example. And of course, this is in someone who knows how to speak English. And then you look at repetition, you look at comprehension. Do they understand what you're asking them to do? We usually test this in a stepwise fashion, and also you test this being aware of the language that the patient speaks. So we start with the least complex thing, which would be copying. So you try and ask them to copy something that you're doing, and so that's called mimicking. And then you start with a 1-step midline command, like close your eyes, that's a midline command, open your mouth. And then you would go to an appendicular command. Appendicular just means limbs. So for example, lift your right hand or show me a thumbs up with your left hand, for example. And then you go to now multi-step or embedded commands. So these will be several steps. Instead of asking the patient to do one thing, you might ask several things. So lift your right hand, touch your nose, then touch your ear. That is a multi-step command. And so you would go stepwise like that. You can start at a complex command already if you think your patient is comprehending well, or if you think there's problems, then you start more simple and then you get more complicated as you go. Another thing you want to look at in the higher functions is parietal function. And this is typically something that we see with right-sided brain lesions. And so neglect is one of those things. Neglect, also called hemispatial neglect, is usually where the patient ignores one side of the body. So in this case, they'll tend to ignore the left side of the body if they have a right-sided brain lesion. And we can also call this sensory inattention. So they tend to extinguish or they tend to ignore the opposite side of the body when you're examining them. And there's specific ways that we can test for this. You can test for this by writing. You can test for this by touch, what we call tactile sensory inattention. You can test for it by visual, where you do visual stimulation. So if you touch both sides of the body, they will tend to neglect the one side. But if you just touch it on its own, they'll be able to sense that. And then there's also what we call apraxia. So apraxia is an ability to perform previously known or learned skilled purposeful movements. So in patients who then have lesions in the brain, particularly in the parietal region, for example, you might ask them to show me how you would brush your teeth, and they would actually struggle. They won't be able to say hold their finger up and show that they can brush their teeth. And so there's different ways that we can test apraxia. There's also different types of apraxia, but it's something to be aware of as we are examining for higher functions. After you're done with your mental state or higher function exam, the next step is to look at the cranial nerves. And as we all know, there are 12 cranial nerves. And again, we expect a systematic evaluation or examination of the cranial nerves. With the first cranial nerve, we don't necessarily, or let me say routinely, test it by the bedside, but it's always advisable as you see your patient to start by asking them if at least if they're able to understand you, do they have any problems with smell? That's always the start. And then if you do have something accessible that they can smell, particularly we say something like an orange peel or a banana, that kind of common scent, and you check, you would block one nostril, see if they can smell the one, block the other, see if they can smell. Something to note and be aware of here is you shouldn't use something pungent, because then you're actually not testing smell. So for example, you shouldn't get a spirit swab and ask them to smell that, because what that is doing is actually stimulating the painful nerve fibers, which is cranial nerve 5. So you're not testing smell. So just be aware that you need to use a mild scent and a scent that the patient should be able to recognize. And then your optic nerve has several facets to it. So that's your cranial nerve 2. You start by visual acuity. There are many apps now that you can use to actually test, almost like a mini Snellen's chart on your phone. But you can also do simple things. Firstly, ask the patient if they're having trouble seeing, see if they can count fingers. If you have some text somewhere, if you have a notebook, you can check if they can read. Or if, say, there's some writing in the word, see if they can read, and you can comment on that. Visual fields as well, we do by confrontation. It's always useful to learn how to do a fundoscopy. And in the fundoscopy, apart from generally looking at the retina, for the nervous system, we are looking at the optic disc. So we're looking at the size, we're looking at the boundaries, that they are sharp and that there is no papilledema, for example. And then you can also test with the optic nerve, because as you know, the pupillary reflex involves both the optic nerve, cranial nerve 2, and the oculomotor nerve, cranial nerve 3. So for the optic nerve, we're looking at the afferent part. So the ability to actually detect light when you shine the light into the eyes. And so when you're testing the optic nerve, what you're looking for, we call a relative afferent pupillary defect. So you're shining the light and seeing that the pupils constrict equally when you shine the light rather than dilate, which suggests a relative afferent pupillary defect. And then after that, you're going to look at your eye movements. So that will be cranial nerve 3, 4, and 6, to look at all eye movements in all 6 different positions. Then the trigeminal nerve. The trigeminal nerve has both motor and sensory, so sensation to the face. And as I mentioned, it's also to the inner parts. So it's the inner nose, the inner mouth. And as we know, we have V1, V2, and V3 on the face. And then it's also got a motor component where it supplies to the chewing muscles, so the masseters, for example. And so you test those as well. And then you look at your facial nerve, which is the nerve for facial expression. The facial nerve is also for taste. We don't typically taste or examine for taste, but you may ask the patient or they may volunteer that they're having trouble tasting. So tasting of the anterior 2/3 of the tongue. Then the vestibulocochlear nerve for hearing. Again, by the bedside, it's usually confrontational. So you might rub your fingers and see if they can hear. Is there a difference? You might get a watch if you have a ticking type of watch, see if they can hear the ticking, or you can do more complex tests, as you know, with the Rini and Weber's test. But if you're just doing a routine exam and it's not the primary complaint of the patient, we do not necessarily expect you to do Rini's and Weber's in your usual neurologic exam. Then the glossopharyngeal and vagus are also generally tested together, which is looking at the soft palate. And so you're looking to see if the palate rises symmetrically. You're looking to see that the uvula rises symmetrically. You're also listening to see if there's any hoarseness of voice, if they've had any trouble swallowing. It's something that you can ask, and it's something you can see if the patient has a nasogastric tube in situ. That will suggest to you that they may actually have problems swallowing. It's also about the gag reflex. Again, not usual, especially in someone who's alert. We do not usually test for gag, but if someone has a depressed level of consciousness, for example, that might be something you might want to check for. Then we've got the cranial nerve 11, the accessory nerve, and this is the motor supply to your sternocleidomastoid muscles and to the trapezius. So it will be testing your patient to push on the one side, push on the other side, looking at opposite sternocleidomastoids and shrugging of the shoulders and feeling for that power that will test for the trapezius. And finally, it's the hypoglossal nerve, which is motor to the tongue. So again, you're listening to see if there's any dysarthria. You ask the patient to move the tongue. You look at the tongue bulk, is there any wasting? And those would have been all your cranial nerves. So systematically, even as you report your history, even as you report your examination, we want to hear that you've gone through those 12 cranial nerves. Next, we go to the motor system. So your motor system will be looking at your upper limbs and your lower limbs. And you always begin, as you know, with just any examination, you start with inspection. So look carefully at the arms, look carefully at the legs. You're looking at the bulk. You're looking for any abnormal movements. Are there any fasciculations, which is just twitching of the muscles on their own? Is there any other jerks, which we call like myoclonus, for example? Is there any abnormal position, which is called dystonia? Is the leg twisted in an abnormal way? Are there any other abnormal movements, like a tremor, for example? You want to comment on all those things. And then you are going to look at your tone of the muscles. So the tone is actually feeling now. So you feel, and your feeling, is the tone low, meaning it's flaccid, or is the tone spastic? So is it increased? An increased tone could be spasticity, where we call it a clasp knife. So it catches, then it releases, and you feel that it's velocity dependent. So you feel it, you do a quick motion to see if there's a catch and a release. And then you do a quick motion and then a slow motion to feel if there's rigidity. And so rigidity, we say it's lead pipe. It will be high all through the motion. So there'll be no change as you go through the motion, whereas with spasticity, it will be high and then it will break. And then you also feel for other signs like cogwheeling, for example. As you rotate the wrists particularly, it might feel like it's breaking, as if it's going through gears, and we call that cogwheeling. And then next, you will do the power, which is something you must do in conjunction with the patient. And generally, you need the cooperation of the patient. It can be really difficult if the patient's not cooperative, but we grade power from 0 to 5. In the grade 4 has also additional gradations. So grade 4 power is where there is resistance, but it's not full resistance. But we tend to grade that as a mid 4, which is just 4 out of 5, but a 4 minus where there is some resistance that's very little, and a 4 plus where the resistance is almost full, but not yet. So only grade 4 has a 4 minus and a 4 plus. The rest are just 0, 1, 2, 3. Then you have 4 minus, 4, 4 plus, and a 5. So 0 is no movement at all. 1 is there's a flicker of movement. 2, it says movement, but it's not against gravity. So they can move laterally on the bed, but they can't lift off the bed. 3 is when you can move your limb against gravity, so you can lift it off the bed. And then 4 is with some resistance, but not full resistance. And 5 is normal power when there's full resistance. To end your motor examination, you look at reflexes, and we look at reflexes. So these are routine reflexes because you can do many other reflexes, but routinely in the upper limbs, we do reflexes at the biceps. So it's where you hammer your patella hammer or your reflex hammer at the biceps tendon. You do the triceps, which is just posteriorly behind at the elbow, your brachioradialis, the distal forearm on the radial aspect. And then you can also look at the finger flexor reflex, also called the Hoffman's reflex. And then in the lower limbs, we generally look at the knee jerk or the patella reflex and the Achilles or the ankle jerk. And finally, you do your plantar reflex, which is the Babinski, where you're looking for an upwards or a downwards response. When you're done with your motor exam, you look at sensation. And sensation has several modalities, and it is important when you do your examination to try and assess each of these different areas. And so you want to look at light touch. So that's just generally touching with your fingers, just stroking the patient to see if they can feel. And then temperature. Temperature, we usually use something cold rather than hot. You don't want to burn your patient. So find something cold, and something cold tends to be, if you've got the queen square type of hammer, the base of the hammer has a cold metal surface. So you can use that. If you have a tuning fork, that can also be quite cold. Or even your stethoscope, there's the little tubes for your ears, those metal parts, you can also try to use that. So try to use something cold rather than hot to be safe. And then you can look for pain as well. Pain as well, you want to use something sharp, but not something that will break your patient's skin. So a toothpick is generally considered quite nice and safe to use. You can also use the tailoring pins if you have access to those. They are sharp, but don't break the skin. Or a drawing pin, those pins that we use to stick on the notice board. Again, those are just sharp enough, but not too sharp. Please do not use the needles that we use for drawing blood. Those are going to injure your patient, and that's not the aim of your neurologic exam. And then finally, you're going to look at vibration and proprioception, also called the joint position sense. And so you test that in the fingers and in the toes, and then you can end that by also doing a Romberg's. And the Romberg's test is essentially where you ask your patient to stand and to close their eyes, and you watch for them falling over. If they just sway but don't fall, that's not a positive Romberg. So essentially a positive Romberg is if the patient falls over. So just a note though that you should be there available to catch your patient. You do let them fall to the ground. So as you do your sensory examination, you're looking for differences between left and right. You're looking for differences between proximal and distal. You're looking for symmetry. Is it the same on both sides, or is there asymmetry? You're looking for any dermatomal distribution. Is it fitting in a particular dermatome or fitting in a particular nerve, for example? And then we go to coordination, or the cerebellar exam. And here we do a finger, nose, finger test. So that's in the upper limbs. So essentially, you're going to put your finger in front of the patient like that. You should ask your patient to hold their arm up, out, away from their body. Then they'll touch their nose, touch your finger. Touch their nose, touch their finger, and you do the same on the other side. The arm should not be against their body because they might use that for support. So remember, the arm should be out, then stretch, and they should stretch all the way out. So your finger should be far enough that they could stretch. Take note that if someone doesn't have proprioceptive loss, they can actually do this with their eyes closed, and it can be done in someone who is blind by actually using their own arm. So you ask them to stretch out their own arm in front of them. Then they put the nose in the finger. So with their eyes closed, you can touch your nose, finger, and you actually don't need to have your eyes open. So this is something you can do in someone who has visual impairment, or say, for example, has double vision. You can actually ask them to use their own arms to test. Then you can do the heel-shin test. So for the heel-shin test, we're testing for cerebellar function in the legs. And what you do with the patient lying supine in the bed, you ask them to raise their leg up, then put their heel on the knee and slide it straight down their shin. So it's leg up, heel on the knee, and then straight down their shin. And you do that both sides, noting that this could be difficult in someone who's got weakness in the leg. And if that's the case, you just report if there's such difficulty. Finally, we look at tandem gait, which I'll comment on more in the next part of the examination as we look at gait. And so when you're assessing the gait, you ask your patient generally to stand up. And so you should watch as they're getting up, because that also gives you a lot of information. Do they need to support themselves to get up? Does it take them ages to get out of the chair, or can they get up quite quickly? Do they get up too quickly, as if almost impulsively? And that you should take note of. Then as they start walking, look at their stance. Are they broad-based, or are they narrow-based, or are they just right? You want to look at the stride length. Is the length normal, or are they shuffling, as you would see in Parkinson's, or are they flapping their feet, stepping up, like what we would call a high stepping gait? So you look at all those things. You look at their posture. Are they upright? Are they stooped? Are they swaying to one side as they walk? And how are their arms swinging? Are their arms swinging appropriately? And then as you do gait, we look at what we call tandem gait, as I said, which is part of coordination. And this is where you ask the patient to walk in a straight line. It's usually the test they do, like for drunkenness, actually. So you walk in a straight line, 1 foot in front of the other, 1 foot in front of the other in a straight line, and that tests for cerebellar function. And it particularly looks at midline or vermal cerebellar function. We also can do heel walking and toe walking, which is actually testing for power distally in the ankles. So looking at both ankle flexion and dorsiflexion. So we do that with the gait. So when we're done with all this, it's not just a charade, and we're not just doing it for the sake of it. We are trying to find a location. We're trying to localize, and that is the beauty of neurology. So what does this all mean? You should not get caught up in the nitty-gritty details of the examination. Quite all right, you'll find so many things, you've done so many things, but think about it as a whole. Think about how you can summarize. So you're looking for patterns of abnormality. Were the findings that you had, were they symmetric or asymmetric? Did they seem to be a proximal to distal gradient? Were they predominantly upper motor neuron signs, that's brain and spinal cord, or were they predominantly lower motor neuron signs, which is in the nerve roots, which is in the peripheral nerves, the muscle, or the neuromuscular junction? And then use your pattern of the abnormalities to localize where this problem is within the nervous system. Because we're asking ourselves all the time, as we take the history, as we examine, where is the lesion? So these are some clues that can help us when we're thinking about in our examination. So we are looking at upper versus lower motor neuron pattern. So in upper versus lower motor neuron pattern, particularly, so in the muscles, you're going to look at the tone. If it's upper motor neuron, there'll be spasticity, whereas lower, there'll be hypotonia. The bulk will be normal in upper motor neuron, where there'll be wasting or atrophy in lower. There will be fasciculations in lower, but none in upper. The weakness, the pattern of weakness is actually very useful. So in upper motor neuron pattern, the extensors are weaker than the flexors, whereas in the legs, the flexors are weaker than the extensors. And you can imagine when you think about a patient who's had a stroke, they'll usually have their arm flexed to them, but their leg will be extended and they walk in this circumducting way. So you think about that because their extensors are strong in the legs and their flexors are strong in the arms, and that's an upper motor neuron pattern. You won't see this pattern in lower motor neuron lesions, and typically in lower motor neuron lesions, distal is weaker than proximal. Reflexes will be increased for upper and they'll be reduced for lower. The Babinski will be down or mute in lower, whereas it will be upgoing in upper motor neuron. And so this is something that can help you as you think about patterns. You also think about patterns with regards to where it's happening. So that was upper and lower, can be anywhere. It could be brain, spinal cord, roots, it could be anywhere. But you want to think, can it be in the cerebral hemispheres? And so you look for what we call cortical features. So things like aphasia, neglect, apraxia, those are cortical features and point to cerebral hemispheres. They tend to be one-sided unless they are multifocal lesions. And when you have predominant ataxia and dysmetria, you think of the cerebellum. When you have many cranial neuropathies, you think of the brainstem. And one thing that's peculiar and that you should be aware of in the brainstem is when you've got crossed signs. So if you have got signs on both sides of the body involving the head and the trunk, you should think about the brainstem. Whereas if you've got signs on both sides of the body below the neck, you would think about the spinal cord. Again, with the spinal cord, especially if it's half a lesion, because you remember there's always fibers crisscrossing. So some of the fibers that cross are the sensory fibers, the ones for pain and temperature. So you might find if you've got half a cord lesion, what we call a hemicord syndrome, you find that on the one side, there's weakness and proprioception loss, but on the other side, there's pain and temperature loss. That tells you that it's a spinal cord problem. What really points us to the spinal cord is when you've got a spinal level. So whenever you examine your patient and there's, say, a sensory level, they can't feel up from this point down, that's always a clue that it's in the spinal cord. And then as we go now to lower motor neuron, we start really from the top and go down. And the top of the lower motor neuron is the nerve root. So from the spinal cord, as you come out, the first part of the lower motor neuron, what's outside the central nervous system, will be your nerve root. And so you look for root patterns. So nerve roots have myotomes, they have specific muscles they supply, and they have dermatomes, specific areas of skin they supply. So if you find patterns that's suggesting of roots, you would think of nerve roots. Sometimes it can be nerves. So for example, you can have a median neuropathy in patients who have carpal tunnel syndrome. And so only the nerves that are supplied by the median nerve will be affected. Only the areas supplied by the median nerve will be affected. So for example, in a median neuropathy, you'll get loss of sensation in the hand, which will affect these 3.5 fingers. And then you have weakness of this abductor pollicis brevis muscle. And so that kind of pattern will tell you that it's a median neuropathy. So you look for such patterns to see if it's a particular nerve that's actually been affected. And it will tend to be asymmetric because one nerve might be affected in one way, and in the other hand, it might be a different nerve or no nerve at all. And so you think about that. But there are times when you can have multiple nerves affected almost simultaneously, and we call that a polyneuropathy. And what hints to a polyneuropathy is distal weakness if it's motor, and also a glove and stocking sensory loss when we talk about sensation. For the neuromuscular junction, these are a specific type of syndromes that we see, and one of the commonest conditions would be myasthenia gravis. And in here, you tend to see proximal muscle weakness. And the hallmark of this is that it's fatigable. So they'll tell you that they get weaker as they exercise, and when they rest, they feel stronger. And that becomes a hallmark, and there'll be no sensory symptoms. And so that tells you that it's neuromuscular junction. Whereas if it's purely muscle, there might be pain. It again will be proximal more than distal. It will be symmetric, but it will not be fatigable. So how do we put all of this together? So when we approach neurological disease, the first thing is to take a detailed history. And as you take this history, you want to generate a hypothesis about where the problem will be. Once you've started generating this hypothesis, you use your neurological exam to put that together with your history, to see how you can match your history with your examination findings, and then you come up with a location. So you use the pattern of the abnormalities that you found from the examination to refine your localization. Once you know where the lesion is, it's not the end, unfortunately. So you know and say, okay, from everything I've got, the problem is in the left cerebral hemisphere. Now you want to ask yourself, based on some of that other information, how sudden was it? How did it progress? What's your differential diagnosis? So what are the possibilities? So say you've localized and say, okay, it's a left cerebral hemisphere problem. Now there are many differentials. Is it a stroke? Is it a tumor? Is it inflammation? Is it like demyelination? So then there are other differentials, and those differentials will be based on other aspects of your history and your examination that you found. All right, so that's the end. If you have any questions, feel free to send me an email, and I hope the lecture was clear. Thank you.